Hello everyone and welcome. Today we're going to be learning about inflammatory bowel disease, or IBD. This is a term used to describe chronic inflammation of the digestive tract, and there are two recognized forms of IBD. So these are ulcerative colitis and Crohn's disease. So these are two very distinct conditions that come under the term inflammatory bowel disease. As you can see here in this image, we can already spot some of their differences, but we will go into more detail in this video. Now just bear in mind that there is some degree of overlap between these two conditions, and sometimes they cannot be differentiated. So the etiology or the cause of IBD is unknown, but it is believed to be an autoimmune disease. So IBD is a long-term condition characterized by periods of active disease and periods of remission. There is a peak incidence between 15 and 25 years of age, and people of Jewish descent are more prone to developing IBD. Some of the common signs and symptoms to both ulcerative colitis and Crohn's disease include diarrhea, abdominal pain, blood in the stools, fatigue, and unintended weight loss. Now, a lot of these symptoms may raise our suspicion to bowel cancer, as cancer can lead to all of these symptoms, perhaps not so much to abdominal pain, but it is still something we should bear in mind. So we really need to understand how ulcerative colitis and Crohn's disease affect our bodies to be able to make the correct diagnosis. So let's talk about ulcerative colitis first. So this is an inflammatory bowel disease where inflammation and ulceration of the colon is observed. So if we just pay attention to the name, ulcerative means presence of ulcers. Colitis means inflammation of the colon. This is the large bowel. So we're going to see continuous colonic lesions, meaning it does not affect the small intestine. They are colonic lesions only. There will always be rectal involvement. So obviously, like everything else in medicine, there are always exceptions, but as a rule of thumb, there will always be rectal involvement in ulcerative colitis. So ulcerative colitis will start at the rectum and extends proximally through the colon. So as we can see in this image, we have the rectum here, it's very inflamed, it's red, and the inflammation essentially spreads up throughout the colon, but it would never affect the small bowel or anywhere else in the GI tract. So in terms of the gross morphology, ulcerative colitis will affect the mucosa and submucosa only. So here we have a section through the large bowel, and we can see all the different layers. So here's only the submucosa and the mucosa that are affected in ulcerative colitis. And this is in contrast with Crohn's disease, where we will see a transmural inflammation, so affecting all the layers of the colon. Friable mucosa can be seen in ulcerative colitis. Here we have an image of ulcerative colitis, and in comparison to a healthy bowel. Friable means it will bleed easily. So let's say if we touch the wall here of the bowel, it might start bleeding. In ulcerative colitis, we will see superficial and or deep ulcerations. And another thing we can see in this image, in contrast with this one, is that here we can see all these divisions in the colon. These are called the haustra. So as up here as well, various different divisions. These are the haustra. And in ulcerative colitis, you get the loss of these divisions. This is also a characteristic finding of this disease. So like I said, we have loss of haustra, leading to a lead pipe appearance on imaging. So here we have the large bowel, so the descending colon here. You can really see how it just looks like a continuous pipe, like a lead pipe, and there's the loss of haustra. Next, pseudopolyps may be observed. So this is an image of a colon with severe ulcerative colitis, and we can see a lot of these polyps. but they are not true polyps, they are pseudopolyps because they are caused by the healing of ulcers. So essentially there were many ulcers in this bowel, and as the body heals those ulcers, it will essentially put there a little bit more tissue for some extra protection, and essentially ends up forming these polyps. So microscopic morphology now of ulcerative colitis. We will see crypt, abscesses, and ulcers. So here we have an image of normal bowel. So these crypts are part of the normal bowel. We can see them here. And in ulcerative colitis, because of the extensive inflammation, we have a lot of neutrophils in the area, and they can end up essentially clogging these pits and forming abscesses. So this here is a crypt abscess. And now in a histology slide, what it would look like. So for example, here we have a crypt, and inside a bunch of neutrophils. So this is a crypt abscess. Also, ulcerative colitis is a T helper 2 mediated response, meaning it will produce a humoral immune response. So a humoral immune response is that involving antibodies and complement proteins instead of a cell-mediated response, which is seen in Crohn's disease. So some of the signs and symptoms more specific to ulcerative colitis will be bloody diarrhea, which is the most common sign of ulcerative colitis. There will be varying degrees of abdominal pain depending on the severity of the disease, but left lower quadrant pain is common. So if we look here at the left lower quadrant, this is where the descending colon and the sigmoid colon would sit. And we know these are the areas that are most commonly affected by ulcerative colitis, so you would see left lower quadrant pain quite commonly. You may see nocturnal diarrhea. This is essentially an indication of how bad the diarrhea is. So you can have really bad bloody diarrhea in ulcerative colitis. There can be some mucus discharge from the anal region. Tenesmus, which is the feeling of incomplete emptiness after opening your bowels. There can be weight loss and fever. So here we can have a look at some of the types of ulcerative colitis. It is essentially a classification depending on where the inflammation has spread to. So if the inflammation is just affecting the rectum, it is termed proctitis. Then we have proctosigmoiditis, which is affecting the rectum and the sigmoid colon. Distal colitis, essentially up to the splenic flexure. Extensive colitis up to the hepatic flexure, and then pancolitis is the whole large bowel. And one thing that we can see in pancolitis, whenever the inflammation involves the cecum here, we may see something called backwash ileitis, which is essentially inflammation of the ileum as well, which is small bowel, due to the close proximity to the inflamed cecum. Next, let's talk about the Truelove and Witts severity index for ulcerative colitis. This is how we're going to classify the disease into mild, moderate, and severe disease. So here are some of the parameters we have a look at. So the amount of bloody stools per day, so if it's less than 4, 4 to 6, or more than 6 bloody stools per day. Pulse, the patient's pulse, the patient's temperature, the patient's hemoglobin. This would essentially indicates as anemia. So if there's extensive bleeding, patient would likely be anemic. Next, we have erythrocyte sedimentation rate and C-reactive protein. These are acute phase reactants. So they are proteins that increase their plasma concentration in response to inflammation. So essentially this would indicate how severe the inflammation is. Now, it is important to establish the severity of ulcerative colitis because it can have some really life-threatening complications. One that we will talk about now is a toxic megacolon. So this is a rare but serious complication of ulcerative colitis, And it happens essentially due to the cessation of colonic contractions. The reason for this is poorly understood. However, it is believed that the overproduction of nitric oxide, seen in that severe inflammation, essentially inhibits smooth muscle tone, leading to a rapid intestinal dilation. So the walls of your intestine start dilating. This will essentially lead to colon wall thinning, so they will become very thin and are prone to rupture. And here's where we're very worried, because then we're going to have bowel contents all over the peritoneum, sorry. This will lead to peritonitis, and the patient can become septic and die. So here we have an image from Radiopedia showing what a toxic megacolon looks like. You can see it's extremely dilated, covering all the abdominal cavity. Let's talk about the extraintestinal manifestations of ulcerative colitis. So first, here are some extraintestinal manifestations common to inflammatory bowel disease, so to both ulcerative colitis and Crohn's disease. So we can have erythema nodosum, which is essentially swollen fat under the skin that will cause bumps and patches that look red or darker than the surrounding skin. We have pyoderma gangrenosum. This is a rare condition that causes large, painful ulcers to develop on your skin, and it is seen most often on patients' legs. And then aphthous ulcers are essentially ulcers who will develop commonly in your mouth. So this is a good examination. It's good to examine patient's mouth when you're suspecting IBD. Some ocular consequences includes episcleritis and uveitis. So that's the inflammation of the episclera and the uvea. The uvea can also be called the iris, so it's the colorful part of your eyes. Some MSK consequences include migratory polyarthritis, which is a condition that affects multiple joints in a progressive manner. So it might migrate from one joint to the other. Then another one is ankylosing spondylitis. This is a condition where you get gradual fusing of the vertebrae, so you lose a lot of mobility there. Now, an extraintestinal manifestation more particular to ulcerative colitis is primary sclerosing cholangitis. This is essentially inflammation of the biliary tree causing scarring of the bile ducts. So here we have an image, and essentially all the bile produced by the liver, right, and the bile stored in the gallbladder, all go through all of these ducts to be excreted into the small intestine. And so if there's inflammation of the biliary tree, the ducts will become hardened and narrow, because you get the deposition of fibrous tissue in these ducts. And this essentially increases the pressure in the biliary tree and leads to a backflow of bile into the liver and increased pressure within the sinusoid spaces in the liver, essentially leading to a gradual liver damage. It can be very serious. Now, ulcerative colitis also increases the risk for colorectal carcinoma, and it's something to keep an eye out in patients with IBD. So just as a quick revision of what we talked about in ulcerative colitis, try to remember just ulcers with 3 C's. So U standing for ulcers, L standing for large intestine, so the disease only affects the large intestine when it comes to the GI tract. C meaning continuous, so we have a continuous lesion. Another C for colorectal carcinoma, there's an increased risk of colorectal carcinoma. C for crypt abscesses. E as for extends proximally, so the inflammation will extend proximally throughout the colon. R for red diarrhea or bloody diarrhea. And then S for sclerosing cholangitis, which is that extraintestinal manifestation that we just talked about. So now let's talk about Crohn's disease. So this is an inflammatory bowel disease that affects any portion of the GI tract. So literally from mouth to anus, it's any part of the GI tract. However, it usually will affect the terminal ileum and the colon, and it will rarely involve the rectum. So there will be rectal sparing. So Crohn's can affect one small area of the gut or multiple areas with normal bowel in between. This is called skip lesions. So here in this image we can see, it even shows a little bit of rectal sparing there, but we can see areas of the bowel that are affected by the disease, so here for example, and then areas of normal bowel, then affected bowel, normal bowel, and so on. So this is characteristic of Crohn's disease, these skip lesions. In terms of gross morphology, we will have transmural inflammation, meaning all the layers of the colon will be affected by Crohn's disease. So this is important. Transmural inflammation can lead to fistulas. So a fistula is an abnormal connection between body parts. Essentially, because you have transmural inflammation, this can spread through the wall of the intestine into another part, let's say of the intestine, as we can see in this image, creating an abnormal connection between these two loops of small bowel, or as we can see here, between the small bowel and the large colon. And this can actually happen between any part of your body that comes in contact with the GI tract, really. So we can have an enterocutaneous fistula. This is a connection between your bowel and your skin. So there can be an opening to the outside environment, which can be very dangerous. There can be an anorectal fistula. These tend to be quite common. Entrovesical fistula. This is a connection between the bowel and the bladder. So you can have a situation where a patient is essentially peeing feces. Here in this image is just to show again the skip lesions in the bowel seen in Crohn's disease. Another characteristic finding of Crohn's disease is a cobblestone mucosa. Essentially, because we have deep ulcers due to that transmural inflammation, you're going to see these deep ulcers and fissures that will produce a cobblestone appearance in the bowel. So you're going to have essentially fissures and deep ulcers in areas of more raised bowel. So it ends up looking like a cobblestone. Here we can see as well what that is meant to look like. So a cobblestone appearance inside there, the large bowel. Another thing we see is creeping fat and bowel wall thickening. So here, as we can see, in comparison to a normal bowel in Crohn's disease, the affected area will have very thick walls, and creeping fat, essentially there will be more fat around the bowel surrounding it. Now, the bowel wall thickening leads to the string sign on barium swallow. So here we have an image. Essentially, a patient swallows a barium solution. It will allow for contrast on imaging, and we can see these strings. It literally looks like strings because these areas of affected bowel will have a thicker wall, meaning not so much space there for bowel contents to be, and it ended up looking like strings. Now for the microscopic morphology of Crohn's disease, we will see non-caseating granulomas and lymphoid aggregates, usually located in the mucosa and submucosa. So essentially, a non-caseating granuloma means there is no central necrosis inside the granuloma. And we can see this here in the center. There are many white cells still, so there's no necrosis in the center. This is just an image of a granuloma. And essentially, Crohn's disease is a T helper 1 mediated immune response, meaning it is a cell-mediated response. So cells are going to be recruiting more cells and trying to wall off the source of inflammation and essentially form this granuloma. Some of the signs and symptoms more particular to Crohn's disease include diarrhea that may or may not be bloody, and it's often mixed with mucus. So in ulcerative colitis, it's very common to have bloody diarrhea, but in Crohn's disease, it's not as common. So there will be varying degrees of abdominal pain depending on the severity of the disease, but a right lower quadrant pain is common. So like we talked before, Crohn's disease often affects the terminal ileum, and the terminal ileum sits around there where it connects to the cecum, which is right where the right lower quadrant covers. So you will see right lower quadrant pain quite commonly with Crohn's disease. There will be weight loss, fever, and tiredness. So now for the extraintestinal manifestations of Crohn's disease. Here first we have the extraintestinal manifestations common to inflammatory bowel disease, so to both Crohn's and ulcerative colitis. So erythema nodosum, pyoderma gangrenosum, and aphthous ulcers in the dermatological side of things. Ocular consequences, we have the episcleritis and uveitis, MSK, migratory polyarthritis, and ankylosing spondylitis. Now, the more particular manifestations to Crohn's disease will include kidney stones and gallstones. So essentially, in Crohn's disease, we're going to see fat malabsorption because of that small bowel involvement. And so fat that will be in your bowel will bind to calcium. It's in a process called saponification. And this means that oxalate will be free to be absorbed, because usually calcium binds to oxalate, forming calcium oxalate. But if this doesn't happen, oxalate is free to be absorbed. There will be an increase in the oxalate levels in your body, essentially leading to the formation of calcium oxalate stones in your kidneys. Here we have an image of a kidney full of stones. Next, gallstones are commonly seen in patients with Crohn's disease because of that terminal ileum involvement. So if the terminal ileum is inflamed, there will be a malabsorption of bile salts. And an imbalance of bile salts in the gallbladder essentially leads to an increased risk of developing gallstones. So just a quick summary for what we talked about in Crohn's disease. You're going to have inflammation anywhere in the GI tract, so from mouth to anus. You're going to have skip lesions, so patches of inflammation in between healthy portions of bowel. The pain is typically in the right lower quadrant due to that terminal ileum involvement. You're going to have transmural inflammation, which can lead to fistulas. It is a T helper 1 mediated immune response, which essentially leads to the formation of non-caseating granulomas. The bowel will have creeping fat, a cobblestone mucosa, and rectal sparing. And then stones are more common in Crohn's. So you're going to have gallstones and renal stones. So here, just this image is great. It is an image from the Canadian Digestive Health Foundation. It essentially just summarizes there the differences between ulcerative colitis and Crohn's disease. So first, with the location of inflammation, ulcerative colitis is limited to the large intestine, Crohn's anywhere in the GI tract. In ulcerative colitis, we have inflamed areas which are continuous, and in Crohn's, we have patches of inflammation, or the skip lesions. Ulcerative colitis, you're usually going to feel pain on the left lower abdomen, and in Crohn's, on the right lower abdomen. In ulcerative colitis, the ulcers penetrate the inner lining only, so the mucosa and the submucosa, while in Crohn's, it is a transmural inflammation. And ulcerative colitis commonly has bloody diarrhea, while in Crohn's disease, that is less common. Thank you for watching this video. I hope you enjoyed. If you did, don't forget to leave a like and subscribe for more.